Hey guys, welcome to the CPD Junkie podcast, where we bring you interviews with dentists sharing their CPD stories and journeys from around Australia. What better way to learn than to follow those who've already done it before? CPD Junkie is Australia's most comprehensive CPD, so head over to cpdjunkie.com.au and become a member for free to access the full features of the site. I'm your host, Laurence Doan, and today we are joined by Dr. Mehdi Rahimi. Dr. Mehdi Rahimi is an Adjunct Associate Professor at CSU Orange. He also graduated with distinction from University of Otago in New Zealand in 2002 and received the DClinDent Endo degree from Melbourne in 2008. He has been actively involved in endodontic teaching at various continued education levels, both nationally and internationally. He's a guest lecturer at University of Sydney and Melbourne, and a CPD mentor for the Australian Dental Association, New South Wales. Dr. Mehdi Rahimi, welcome to the show.
Thank you very much for that kind introduction, and it's an honor to be here speaking with you, and hopefully we get enough, especially recent grads and young grads watching this, because I've been watching you guys and you're doing a great job at CPD Junkie, and I think I joined OMID about a couple of years ago with Mark Johnson, so it's great to be back. Thank you for inviting me.
Thank you. So before you were a specialist, you're a general dentist working at the Sydney Dental Hospital. Where did your CPD journey start?
Yeah, so it started very early on in my undergraduate years. In my second year as an undergrad student, I visited my uncle Mahmoud Torabinijad, who's a famous endodontist, as most of you know, the author of the Principles and Practice of Endodontics textbook and the inventor of MTA and a number of other products in especially endodontics. So I visited him in the States, and of course he's always been heavily involved in teaching, as everyone knows. So it was nice to see his balance between teaching, which I obviously love, and I come from a family where both my parents are specialists, medical specialists, my sister also a GP. So for example, my dad had been doing a lot of teaching as well, and so is my uncle Torabinijad and a few others in my family, other uncles. So I really liked that side of learning, and eventually I was hoping that I can reach some level of where Professor Torabinijad is. Of course, I'll never get to his level. I don't think I ever will. But at least, I saw the way he does a balance between probably less clinical and more research and teaching. And so I watched him go through his days, and I enjoyed what I saw. A lot of what I saw I haven't even seen in Australia yet. For example, in the private practice setting, we treat one patient at a time as an endodontist, but he had actually like musical chairs, like 5 chairs running at once. And he had a lot of nurses, or I'm not sure if they're hygienists or therapists, but they were doing the temporization, the radiographs, and medicating the tooth. And, a lot of the stuff was being done by them. And he was very quick, and he would go through 5 cases, and within 3 hours, I might have seen, say, 12 to 15 patients, which is pretty much 3 days work for me. In terms of hands-on.
Yes.
I saw a lot. I saw that he was very, very slick. Obviously, being experienced as an operator, he was very slick. So he's also very good hands-on, not just an academic. And I watched him and Professor Goodacre. He's a famous prosthodontist. They're all from Loma Linda Uni. I went to courses there for free, so invited by my uncle. I actually did get into his program in Endo, but I turned it down on the way home, which I had my reasons for at the time. I think it was more family reasons, and the ease of traveling to the States financially, as well as staying there and then sitting the overseas dentist exams before you can actually work in private practice, just wasn't easy enough and was too long. So I decided to apply for a program under Harold Messer at the time, who had written chapters in Prof. Torabinijad's textbooks, and Prof. Torabinijad spoke very highly of him as well. So I ended up going to Melbourne, not the States. But that's where my CPD journey started, very early on, from watching many specialists. And if there's any take-home message from my presentation here, with you, Laurence, is you can never learn enough by watching. And I know there's a lot now available, especially during COVID time, with you watching various specialists on the net. And I think that as you visit specialists, you also see their daily work. You see if it sits with you, how they work. Sometimes it just doesn't sit with some people. They prefer to do a mix of everything. Other times they really enjoy one area of dentistry, and as they watch more, they go, well, this is the sort of area I like to pursue and practice in future. So I think that's where it all started. And then, of course, as I went through Sydney University, being 50% academic, 50% clinical position,
Yes.
What happened is I met a lot of other specialists and spent time in different departments. So I think it's always good to be an all-rounder at the start.
Yes.
And then you'll gauge and find out what you like, and something will sit with you better than others. And sometimes you change your mind. You might start, as I did, with orthodontics and, doing the long course, then realizing, well, that's just too slow and takes too long and a bit too boring. Apologies to any orthodontists watching this or people interested in ortho. It just wasn't for me. And, endo was not even easy for me. I perforated my second or third tooth, upper molar. I still never forget it, gold crown. My boss at the time, which was also Ben Lee's boss, Joseph Shamillian, gave me a tungsten carbide burr. It's the first time I used a tungsten carbide burr. I didn't realize it drills right through the furcation. So I had this whopping, you can see your, I don't know, the whole tooth on the other side, the whole mouth on the other side of the perforation, type perforation. And that sort of, was the start of me hating endo and accessing teeth, and every time being afraid after that, not accessing or incomplete accessing. It took me a long time to practice that till I started to feel comfortable with it, and then I started to enjoy the that particular side of dentistry, endodontics, which was pretty much the bread and butter. Because if I see emergency patients, and I was an emergency dentist in private at the start, I wasn't getting my routine, cases. I wasn't well known. It was important that you be able to extract the tooth with less risk of fracturing roots. It was also important to be able to get the patient out of pain. You only had two options. So I actually started to extract more teeth. I was afraid of accessing. Then I was at the end, staying back till about 10:30, 11 p.m. at night in Liverpool, where I could see more cases than Chatswood, because I was working in two private practices at the same time.
Yes.
Ben's private practice was on the weekend. I was doing night shifts and stuff. And there was a place called George Street Dental right opposite the Sydney Dental Hospital.
Yes.
I used to just go through that tunnel and, spend from 6 to 9:30, and it wasn't very enjoyable. Once I went to somewhere where I could have a good mentor, other senior colleagues, so in a group, I found that I could get a lot of experience very quickly, and I'd do those, Easter weekends and times where others weren't seeing patients. I was seeing emergency patients, and then I towards the end, nurses were like, "Oh, Mehdi's going to start an endo at 9:30 p.m. at night," and I was doing that. I was actually enjoying it. I was like, "No, I'm doing endo. I'm not going to extract the tooth," because they'll come back for the crown too. So it's kind of good both ways, not just experience wise, but also production wise.
Wow. I mean, let's break it down a little bit. So you started in second year. You went overseas. You were observing your uncle doing. You're interacting with other specialists as well, and you were seeing how they were working. You came back and you started, when you graduated, you started working, and then there you started attending CPD courses in ortho. You started attending any other CPD, was it? Before you realized you wanted to do more endo?
So some basic endo restorative courses are done as well. So I've got a little bit to say about that as well. I also really enjoyed the FDI because I was part of the just helping out organizing team committee. Incidentally, again, I'm part of the, sort of being involved in the endo side at the World Dental Congress in Sydney in September. So I was part of organizing that too. But back in 2000 in Sydney, we had the FDI. 2002 it was that we had the FDI. So I saw a lot of international presentations as well as, of course, local presentations. Professor, so for example, Laurie Walsh, I'd never met before. So I saw some amazing presentations, and that also together with watching specialists and going through a program at Loma Linda before I even graduate. It was like a 2-day program in endodontics that I did. They do
Right.
it biannually at Loma Linda. It was a bit over the top, I must admit, but I saw, for example, a surgical molar case live. I saw a retreatment case live. It wasn't like I was going to do that. I wasn't going to come out and be a gun-ho and have a go with that. But it was more just seeing more aspects of dentistry. The more I saw, the more I got driven towards it. And the only thing I want to make is a comment. Sorry, I'm sort of sidetracking.
You're right.
The comment I make is, I think apart from watching specialists and finding your local specialist that you get along with, communicating with them, gone are the days where you write, you just read a report from a specialist, or you write a referral letter to them and you never speak to them. These days are about social media. On Facebook, people ask me questions. I know you have in the past as well, Laurence. And, I try to check them as regularly as I can. On Instagram, people ask me questions. And I give my mobile number to them, especially if they've got an emergency situation, a misadventure, broken file, trauma cases. I always say I'm available. If I'm in Australia, you can send me, a quick, this is a trauma, can you call me ASAP, or call my practice, and one of the specialists, if not me, will come on the phone with you and sort of help you out with it. So that's one side, being close to specialists that you get along with in different fields, finding a specialist that is in a similar age group or similar type of philosophy to you. And of course, that'll be very good. The second thing I'd like to add is try to select programs that are not biased. It's very hard to do that, but an example is the Australian Dental Association, New South Wales, is very heavily involved in continuing education programs. So they have a very strict committee whereby they've got different specialists and very experienced general dentists assessing the program to make sure the program is worthy enough of being advertised. They've got a very strict criteria of controlling. So they really pay attention to the feedback they get from those participants that came. For example, they said too much didactic or too much theory. I want more hands-on. I want an extra day. I want to hear about this or that. So they try to regularly meet the participants' expectations. They've got a lot of people at the ADA, especially New South Wales, organizing these programs. They are the most, I'd say, number one association in New South Wales is way ahead of the others around, with all due respect to the other states. So a lot of people from other states also come to the ADA New South Wales courses, and more importantly, the presenters they pick and select. They're obviously well known, and the presentations they give often is not manufacturer driven. So it's not like, you get up and you say, oh, by the way, I taught you to use this file, but here it is, you can buy it at 10%, 20% discount. They try to sell you the new file, which is better than the rest. That's very anecdotal, non-evidence-based. I'd rather go to programs where they teach you exactly how they treat the case. And every specialist might teach you a different way in that program. Yeah. And you also have all the sponsors there. You have all the companies giving and sharing their products with you. It's not like they expect anything in return. And, some people will prefer this product to the other. And of course, there are these, there's this variation in someone preferring one product to the other, but there's different ways to skin a cat, and I'll find a better way to say this if you're a vegetarian, but there's different ways to do things to reach central station. You can take different, ways and forms. It doesn't matter how you get to it. And it doesn't mean that one particular program is better than the rest. So some of those smaller programs, which may teach you something, just remember that you should probably look into programs which are collectively a lot of specialists and different specialists, different age group specialists, different experiences are involved in with multiple sponsors.
Yes. I think that's interesting that you talk about it. So I guess what your takeaway was from attending all your different CPDs early on was to find courses that aren't biased, because a lot of the earlier ones you felt was like trying to sell you something. And
Yep.
a lot of the other thing you mentioned was that you find reputable speakers, you know, whether they be specialists or of the sort that know what they're talking about, as opposed to someone else who might be a bit more biased to some of the material that they're talking about.
Yeah. So
Yeah.
no financial interest or admitting to a financial interest when you get up and you speak about a product or a material or a new technique, and then you teach them hands-on or whatever. So I do like the hands-on courses. I think as many hands-on programs as you can get, especially initially, would be great.
Yeah.
Of course, these periods are a little bit more difficult with COVID restrictions, but
Yes, they
I'm
are.
sure after October, especially even in New South Wales, there'll be programs, and we're aiming to run back to the mini residency module 3 in end of October, and by then, you know, there'll be strict protocols for COVID. But
Yes.
the more hands-on, the better, and just be careful. Use your own logic and common sense when you listen to someone say this is the best product or technique and no one else can match this, you know, oh, it's changed or revolutionized dentistry. I mean, be open to change, whether you're old or young, whether you're
Yes.
set in your ways. Always be open to change. This is the thing about specializing, because you learn that you've got to trial new products, and you've got to be open to change when people say, oh, you access teeth this way now. Because the way I accessed before, I thought was conservative, but it wasn't. It was, you know, even under the microscope, we used to have a lot bigger accesses. And with time, with new technology, with new files, we're getting smaller and smaller, and still yet achieving where we need to be in terms of antibacterial efficacy of the instrumentation and everything.
Yeah.
So I think be
I
open
mean,
to change.
yeah. I mean, in regards to that, I mean, whilst we're on it, practitioners will probably be looking at, yeah, we attend a course, we'll learn about it, but then how often are things changing? Because a lot of times there's multiple different rotaries out there. You know, how often should they be changing systems? Because then they feel like the expense starts to rack up, right?
Yes, yes. So, and you're exactly right. So if you're a practice owner like myself, I mean, I try to be as generous as I can and get everything up to date, but there comes a limit. You have a budget, and you just can't keep spending on new products that come out every single month.
That's
The
right.
reality is there's so many products, and there's even more products, and as we speak, more is coming out. So if you were going to bring on every single new product into your practice, you'll be bankrupt. Like head bankruptcy, or, you know, it's going to be a very, very expensive part of you'll have to stop and be reasonable and logical. I
Yeah.
think the way you assess products, and the way I assess products as a specialist, which I'm sure even if you're a younger graduate, you would understand. It's a way of logically going through the evidence, looking at whether there's actually systematic reviews on that particular product type, or technique, or the file type, looking at what the reviews tell you, because a systematic review in a peer-reviewed journal would have already sieved out all the poor papers or the biased papers. A series of experts in the field would have, you know, sieved everything out and given you, or chewed the answer for you. So look into that, but you're not going to get, to be honest, systematic reviews on everything. And of course,
No.
when they say it's a new product, they'll be like, it's better than the rest. I think look at some gold standards
Yeah.
in private practice. Ask specialists, ask them why they may recommend something over the other. And then within a year or two, you may revise your practice protocols if you feel that the next product is going to give you more efficiency.
Yeah.
Like, it's got to be, for me anyway, a highly more efficient way, or a more beneficial way, or a better outcome way of treatment. So, for instance, let me just give you a little bit more on what I mean, because it maybe a scenario would be better.
Sure.
I assessed my cases from 2008 when I graduated to 2012, then to 2021. So, you know, I can put up 3 different slides on average molar endo cases of teeth that were minimally restored let's say, or they didn't have like, a heavy access. And I can tell you that my access has changed over this period of time. My tapers cervically, coronally changed. My apical size has even changed.
Yeah.
So how did I get to 2021 from the time I graduated, and what was the differences? Well, I observed my own failures. I asked myself, one of the hardest things, one of the bad days at practice that I still can't come to terms with, or it does really still rev me up, is, and they seem to all come together for some reason. Like you go to your work one day and then you get 3 failures in a row. So it really does your head in. But you need to learn to love your failures, and you need to understand from what happened and give yourself reasons as to why it happened, so you can only improve. Because every day we're learning. Doesn't matter how old I am, how experienced I am, I'm always learning. And I'm always willing to change, and I'm always willing to even listen to my younger associates, because my younger associates will probably teach me more than the older, more set in their way, specialists or my mentors in the past. So the reality is you learn from everyone. You keep up to date, of course, when you've got a larger practice, because you can always discuss cases and learn different ways. And as I said, you learn a lot from even younger associates, the new graduates. As much as they learn from you, you learn from them. There's different aspects of dentistry. They might learn the management side from me, communication side from me, but I learned from them why they treated this tooth this way. And I still remember why I changed over this many years is I saw my cracks. I also saw those younger associates come through. And as I'm assessing their cases, especially in the first 6 months, I'm pretty strict with not letting any case go through the door. And I tell them, look, don't get offended. You can also look at my cases. We share things, we just want to all strive to be better. At the end of the day, we can only learn from each other. So as I'm watching, I'm going, I think for example, he or she prepared this too minimally. I think there wasn't enough apical size. I think this is narrow. It's underprepared. Used to call it underprepared.
Yeah.
Why is he not opening this axis up? Why is he leaving this pop horn behind? And then I realized that actually, in hindsight, the number one reason for failure of endo-treated teeth is either because it was cracked before and it cracks further under cyclic load. Could be the bite. We forget the bite often. But the second reason why the tooth cracked is probably because of our endodontic and the restorative procedures. So I started to look more into that. I started to share cases that failed with Ben, joint cases of ours that failed. I'd retreated the tooth and I brought it out more. And he'd put his, for example, amalgam nair, technique that was very common amongst prosthodontists graduating then, being taught at Sydney Uni and other unis. They would do amalgam nair. They'll pack amalgam in the orifice of the pulp, root canal, and then that might expand and crack teeth. That might create wedging, barreling forces. Or was it my preparation that was a lot larger that led to the failure? Was it my access into the tooth that wasn't thought of very accurately? So you can always assess your own cases and then go, all right, I'm changing to this system, whether it's this rotary versus that rotary versus hand, because I want to achieve this, because I can see that the outcome through my own analysis of cases, as well as what I've read from reviews and, peer-reviewed journals, systematic reviews especially, is telling me I've got to be more conservative. I've got to address it by buying this product, that product, and that product. That's worth it. Going to programs means that you can even go to your boss, your mentor, and go, all right, with a evidence-based approach, I've been to this course in international or local, whatever, and now I'm saying maybe we could look into these too. We might not be able to change everything, but how about if we get this because of these reasons? Then you can actually give them a mini lecture, sell it to them after.
Yeah. I guess I hear what you're saying. So basically, it's a combination of what's evidence-based and good, solid evidence over a long period of time, as opposed to the what's fresh and new, and then combine that with what works best in your hands.
Exactly.
Seeing what works best, and using that combination together to really determine whether you're going to go full-fledged with the new equipment and all that kind of stuff.
Correct. And definitely if you're more tuned in to, say, for example, doing more orthodontics at your practice, then it applies to ortho more than other assets of dentistry that you might be doing less of. If you enjoy your endodontics, then you want to excel in that, then you probably will do more courses in that, and then you'll probably change some of the products there. So it doesn't mean that, you know, you'll have the be all and end all of every specialty and everything that comes out, every gadget that comes out. But over a period of time, again, I say this because specialists definitely think this way when they graduate. It is not like you're going to practice exactly the same way by the time you leave dentistry and you retire. It's an ever-changing, ever-evolving. You can't keep up with the technology like mobile phones, for example.
Yes.
But at least, once every 2-3 years, you can revise that asset of dentistry that you feel may need. You're either practicing more or it might need more revision. And again, being in a group practice, it allows you to do a bit more everywhere, because then, one of your associates one of your colleagues might, prefer this type of treatment more. They may attend those courses more, and then they are more the endo type, based associate, and the other one's in ortho, the other one's in pros and veneers and all, all of that. Yeah.
I want to come back to you for, early on, you mentioned that you perforated through a gold crown. I mean, was that a catalyst to you saying, actually, I want to go and learn more endo? Or, because for some people, sometimes that might set them back and they decide, you know what, I just don't want to do endo for a bit, because that's like a...
so look, I'll be honest, for a while, it's hard to get over a misadventure. I mean, it wasn't negligence, it was just a misadventure, right?
Yeah.
And the same things happen to others when I speak to them, when they fracture a rotary file, and it is a file they may have not used as often or were experienced to use. Then they just move away and they send all their molar endos.
Yes.
And then after a period of time, you realize you can't simply do that if you're in a private practice. You've got to do a fair degree of, all sorts of dentistry and molar endo. So I then saw those particular people do further training. I even saw them eventually buy a microscope, and they love endo. They've done, say, further training and advanced training programs, and they've gone through, say, mini residency, and all of a sudden somebody who wasn't doing molar endo after a broken instrument is doing it now. Same thing happened with me. I mean, for some time in private practice, I just went there and I was dreading the molar access, especially if I couldn't get in and it wasn't like an open pulp chamber, patent pulp chamber.
Yes.
Then, I was so afraid of drilling further because of what happened. I was traumatized. And then over a period of time, with practice on extracted teeth, which I did, just, pick up as many extracted teeth. Peri-involved teeth are often good because they're calcified, the root canals. Yeah. So I started to access, and I asked questions from at that period in time. I was lucky I was still at Sydney Dental Hospital, or United Dental Hospital, what we used to call it before. So I had someone like Professor Peter Duckmanton, for example, and I'd go up to him and go, is this okay? I was practicing on patients in the hospital still. So there was a degree of, okay, I've got insurance, but also reassurance that the hospital setting is slightly different. You're less likely to be sued and get in trouble. But it was more going those nights to private practice, doing those late nights at, I still remember George Street Dental.
Yes.
Where, I became very conservative. And for a period of time, I was avoiding endo, molar endo. I was referring them off rather than actually starting them until I got more comfortable. The more extracted teeth I did, the more programs I went through, and eventually, of course, specialist training. The more mentors I had to come and hold my hand for quite a number of months, if not years, to be honest, maybe over a year even. I had a guy by the name of Dr. Jen Russo from Gentle Dental Care in the Liverpool practice I worked out of, come in many, many times to refine my access or de-roof the pulp chamber that I was afraid of getting into.
Right.
Until I got my confidence back.
Yeah, there you go. So let's put it this way. So you're struggling, but you're trying to improve on your endo, right? And
Yes.
over here you've got Ben, your good colleague. He's doing like crowns, he's doing veneers, he's doing these. I mean, for a lot of new graduates right now, that's what they're kind of attracted to. They're attracted to the implants, ortho. They're doing like the cosmetic veneers and all that kind of stuff. I mean, you yourself, you're struggling here with endo. I mean, why didn't you jump ship and do that? What ended up, how did you end up pulling back into endo?
Yeah, look, I think it was the number of cases I'd seen in my early years, in my first 2, 3 years, that ended up being, because of where we're at at that period in time, Liverpool was far away. It was not like central like it is today.
No, yeah.
Patients there, probably affordability was an issue, so they couldn't see an endodontist for all their molar endo as easily as city patients or east patients. And I think it meant that I've got to try to do as many endos as I can in those periods of times where the timings of my practice were like Fridays, and I did Friday late nights, like it was at 8 till 9 p.m., very long hours. I did Saturdays, but routinely it was Thursday nights, Thursday all day and nights, Fridays night, Saturday 8 till 5, and sometimes even Sundays. So during those periods, you're going to see a lot of emergencies. So as part of seeing emergencies, you're either going to extract, most common is extract or extirpate. And so I started to do more of that. And then, of course, after extirpation, after visit 1, they come back for visit 2 for instrumentation, then visit 3 or 4 obturation. Then you probably would do the restoration. So that was what I was doing a lot of. And I did start to do a lot of onlay work as well, because every endo became an onlay or a crown.
Yes.
And so I focused in or honed in on that aspect of dentistry. It depends on what you do more of. If you go to a practice where they're more cosmetically driven, you might be doing more bleaching, more orthodontics, more aligners, Depends on what you do more of. And I think with doing more and practice, you're going to enjoy that more in a way. And for me, the short answer to why endo, apart from the fact that I enjoyed it more, I think it was more because it wasn't because of my family background, because Professor Torbenijad, as I said in my previous CPD Junkie talk, actually told me, do ortho. It's a lot less stress-free, and you'll earn a lot more money, blah, blah, blah.
Yeah.
I do ortho, but it was more like I tried ortho. I never did ortho in undergrad. We never put a bracket on. And then all of a sudden, I did the long course where you get your own patients and you got to treat your own patients. It was way too slow for me, and it wasn't enjoyable. I wanted the more hands-on, more technically driven side of dentistry. I didn't enjoy the cosmetic cases I did, the 5-to-5s, LVI style cases that I did, which were definitely not right. Definitely wrong from the start. Even, to be honest, the temporizations were wrong. You were cutting corners and short cutting and putting in temporaries that are glued together without, taking them off and polishing them and putting them on single by single. So there was a lot of that I didn't enjoy.
It wasn't to your ethics,
it wasn't to my ethics, as well as I found that I particularly liked only focusing on usually one tooth under rubber dam and just zoom in on something very, very, I guess, narrow in a way, just one tooth under rubber dam with good music, and rather do 4 or 5 of them a day than say 100 patients through ortho. So it was just too much for me. I preferred to just slow and as precise as I can go through that particular case and perform the endo, not forgetting that everything else I learned was very important, because all aspects of dentistry, including especially the bite and the restorative aspect, is extremely important. You've got to think of perio, endo, pros, and never treat the endo in isolation. So I think everything else helped, even ortho, alignment of the bite, all of that helped me become an all-rounder before I start to, go narrow into that field of endodontics.
Right. I mean, how did you find the specialist program when you were going through it?
It was very hard because I was really enjoying my lifestyle. as a as a general dentist. I was doing
Yes.
quite well, especially working out of Liverpool. I was seeing a lot of patients and long days, and grossing pretty well compared to other colleagues. Sort of new graduates of my time. I think
Sure.
it was about 3 years out. Uh, we incidentally studied with Ben, the primaries. I had to sort of drive him towards, please, just study with me, even if you don't want to specialize, because I studied better in a group. I'm like a pigeon. I am better in a flock. That's why I prefer the group practice as well. I always prefer to be with others, not by myself. Ben is
Yes.
probably a little bit at times different. He was more, independent. I was like,
Yes.
can you just study with me? Just sit it anyway. You might change your mind. So we sat
He
the
does
primaries.
credit you for wanting to specialize.
Yeah, no, I appreciate that. And similarly, like, I learned a lot from Ben, and he was a very meticulous operator. I still remember like assisting him in emergencies.
Yes.
I was so bored. Like he would take ages to get his, fine margins of this, say, fractured tooth restoration and polish it and adjust and add composite. And I was his DA, Sunday night at 10:30 p.m. I was like, bloody hell, I want to go to sleep. I got to start in the morning. So yeah, I learned a lot from Ben too. I mean, we, in a way, as you know, we worked together at Chatswood at a specialist center. And
Yes.
I've learned a lot from him, his way of running business, management of business side. He's very strict. There are different aspects of me and different aspects of him, but we just mesh in together really well. And it's good to sort of complement each other in a way. But going back to what I was saying is it's that, look, the specialist program was hard financially. One thing, you got to be prepared. Family wise, you have to be prepared before you specialize. I've known of a number of marriage breakdowns, relationship breakdowns, because of people getting so stressed out through their specialist program. And to do well in a specialty program, specialty with, especially with the ones that are well known or recognized in Australia and other countries, of course, you really have to put the time and effort into it. It is not financially rewarding for those 3 years. You're just spending money
Yeah.
on the program, and you've got to do everything you're asked to do, not just seeing those patients, but spending many nights till I had about average 5 hours sleep every
Wow.
night. I actually adjusted to the 5 hour sleep. It was very hard because I would get up in the mornings and get myself prepared for a literature review I had to do, a seminar I had to do, case presentation I had to do, and then I had to see a full day of patients, clinical days as well. So financially speaking, I learned that you start with barramundi on year one, you finish with soup if you go out to a dinner date. So,
Yeah.
start to go on a diet, a special diet.
Yeah.
So that side, as well as the pressures, I can be honest and tell you one of the hardest times of my life, just for those that may need to think about this, is the failure of my research project towards the latter half of second year. So out of a 3-year program, you're meant to do a minor thesis and conduct a research project. And my research project fell through.
Wow.
Not going to bore you with the reasons of it, but eventually towards the latter half of second year, I was going to quit. So I'd said, look, I don't think I can do another extra year to do another research project. Anyway, Harold Messer was very patient with me because I did my research under Harold. I did the clinical side with the Prof. Parashos take over of Harold's, running the program type thing. So I had both worlds. Harold was very experienced with research. I latched on to a PhD of Harold's, like PhD student of Harold Messer's. Luckily, that PhD student helped me a lot, and I graduated in time. But I still remember my mum at the door of our apartment in Melbourne, and I said, I'm going to quit. I'm about to retire. I don't want to pay for the next semester tuition fees. My mum at the door with her luggage. No, I'm here to make sure you get through. Being Asian background as well, Persians, Asians, how it is. I think you understand me better.
Yes.
That sometimes, at times you make decisions in life, but your parents care so much. Sometimes that care is not always good. Of course, they're a bit too tough on you at times, but she's like, no way, not after, a year and a half, 3 semesters, you're not going to quit in semester 4. You're going to go right to the end. And I said, all right, Mum, well, this is what's happened. So she sat down with me and she spoke to me, and she actually stayed in Melbourne because she was in Sydney.
Yeah.
She lived in Sydney with my dad and everything. And she stayed for, I think, at least 3 months until I got myself back on track. And then when she was sure I'm going to graduate, she left.
It is one of those dark days when, having that support network really comes in handy to kind of really focus you back in on what you actually want and push you through those dark days, hey?
Yeah, and I can't say that enough about my parents. I mean, they've always supported me through all aspects of life. My dad, he has a saying I have in front of me. I'll just show you guys. So this is actually me in IADR, Japan. I won an award for a research thing. This is in Farsi, and it says, persistence is the key to success. So I got that, because I won an award as part of Australia, New Zealand, sort of like an international thing. We had a poster presentation. Then I got invited back to give a live presentation as an undergrad. Mm-hmm. And so it was nice. And I think my dad's practice makes perfect, and persistence is the key to success has always been with me. So I persist until I never give up attitude type thing. That's the problem. Even in Endo, I don't want to give up. I want to get down that canal, and
Yes.
And it is nice. It's always nice to challenge yourself, and yes. With different ways of treating cases. Eventually, you'll realize that there isn't too many cases you can't do. Honestly, I'd say in endodontics, cases that I wouldn't dream of doing when I first graduated. Now I have a way of managing them where I can manage most cases, which is rewarding when you persist.
So it's a combination of having the right equipment, the right knowledge, and then that attitude, and then all that coming kind of together to kind of get you through these tough cases. Exactly.
And I think, look, with good mentorship, or with good discussion of cases with whoever your mentor or your local specialist is, whoever you've gone through their program, if you run cases by them. Last week, there was a certain case, where, to be honest, in this case, the dentist was doing my head in. It was the second time I had a bit of an encounter with the dentist. And the case in short was, he was really upset that I cut crowns off. And he was like, why did you cut this crown off? It was perfect. And I'm like, well, it wasn't. The bite wing's showing potential caries underneath. I went in and I took photos of the caries. And I said, look, I cut crowns off. I don't cut corners. Yeah. Don't send to me. Anyway, I always run cases by Professor Parashos, and he was always there for me. So he wasn't just going through his program 3 years and goodbye. I have every year had many discussions with him through the year, every 3 to 6 months. I update him with where I am in life, and it's nice to have a friend that you've shared your life with through postgrad, and they stay your friend. And Professor Parashos was exactly that. And he's always there to have a discussion about difficult cases, whether it's management or a case where I can't manage, or a case which is complex where I need a second opinion on. I've always had him as a backup, where I've always called him. Apart from that, of course, Professor Torbinijad too. Occasionally I run the case by both of them. I send an email to Prof Torbinijad, send the case, then send it to Parashos, and I just sort of collate what they see, and often they see very similarly. They think the same.
It's good to have a few mentors when you graduate, which kind of leads me to my next question, which is, what's it like when you do graduate, especially, for a lot of specialists, do they consider setting up their own shop, or working for someone first, or working for a team of specialists?
Very good question, and very simple answer for me anyway, like my view. Of course, everyone has a different view. So like my way is the right way. I think you must join a specialist, preferably, in my opinion, a specialist team, because in that team you've got different level of experienced specialists in different age groups. And just like going through the Melbourne Endodontic training program, for instance, I don't like those programs where there's only one main mentor and 90% of your clinical component where you're treating patients, you've only got one mentor. I don't like that. I prefer to have different mentors and experience times with each mentor. And sometimes, you prefer one mentor over the other, so you can select that mentor again. But I like the group specialist practice. I did the same thing. I joined a group with multiple different specialists in Chatswood before I did my own thing. And that way I learned something from this specialist from this background, who graduated from this uni, and that specialist who graduated from that background, from that uni. And I think you learn from everybody, and you can sort of pick everyone's brain, and you learn possibly more from one to the other. But it's always good to be in a group practice. I never would contemplate setting up my own business too early. I think the first 18 months to 2 years is really honing your skills. It's the same with a new graduate. How could you even imagine setting up within 6 months of graduating? That's just ridiculous. We did have one guy, I'm not going to obviously name him, but he was a colleague of ours. He was an undergraduate. We were undergraduates. We went through the same program as Ben Lee as well. And this particular guy was one of the top guys in the class. He was always very good at what he did. But one of the mistakes he did, which drove him away from dentistry, and today he doesn't practice any clinical dentistry, or he didn't enjoy it anymore, was setting up his own business within 6 months and placing implants too early. Doing a 2-day Nobel Biocare program and then passing, or 2-week program, and placing implants straight away. I think that's a bit too quick and gun-ho.
Yeah.
I think there's so many aspects of dentistry that you need to learn. For the first 18 months to 2 years, you should only focus on your clinical cases, really. And some people take longer than the 18 months, 2 years. That's just an average. They may take 3 or 4 years before they are very comfortable with most of the clinical cases that I've seen through those years, and they can manage most cases on their own. Then comes the other side of dentistry, the practice management side, which is a side which I even don't enjoy today.
Right.
The nursing side, the manage the dentist and the patient side, all of those, the complaints side, the HR side. And of course you get better, and you get help from experienced practice managers, and you get more experience with time. You may even, hire special companies such as Employee Sure, for example, who can assist you with that. But at the start, that's the last thing you want to worry about. It's all about every case needs to come out as best as possible in terms of clinical competence, in terms of patient management level, how you manage the patient, so that then they can go back to the referring dentist in my case. And because at the start it's very hard, they don't know you. So the referring dentist is going to judge you by 2 things. Probably first the radiograph. Let me pick up the radiograph and have a look at it. How good is this guy? I've been sending to the older guys. Let's see what this new kid on the block can do. And probably they might ask the patient, or they might ask the patient first, how was he? Did you like him? How was he approachable? Was he a good communicator? So there's so many aspects of dentistry that you learn that needs time. So the last thing you want is to squat somewhere and start on your own, or buy over an old practice. That's just, you've really got to give yourself time. The first, I'd say 3 to 5 years, depending on how fast you learn, is a huge learning curve in many facets of dentistry, not just the clinical side.
Yeah, I guess you probably see that from your colleagues when they also graduated, but also from all the associates that you kind of take on.
Correct, yeah, and I see them develop, and then gradually they get faster at what they do, they get more efficient. They get better at communicating most often. They get better at managing the case from start to finish, in the complaint and all that, or picking up the red flag patients, but early enough so you don't get caught, with a patient that's sometimes a crazy patient, or pull your hair out patient, who drives you insane. So, I had a lot more of them at the start because I didn't pick them. But now I've sort of, you get to assess psychology and expectations as well. And sometimes, life is too short to stress about, taking on such cases. Or you might say, why don't you go to the more experienced, specialist across the road? I don't have enough white hairs. Come up with an excuse. I'm not experienced enough.
That's right. I want to change the topic a little bit, talking about specialist clubs. As an executive of the Endodontic Society, how do you curate the talks for the year, knowing that you have a range of skilled clinicians at the table? For when we talk about new graduates wanting to join, when would you say that's the best time, and how do you cater for them?
Yeah. So first of all, before you're a new graduate, if you're a student, I don't know if any students will watch this, but there's a concept, that I've always had, and I drive that. I really believe in this concept of being part of the Education Research Committee at the ADA. We want to attract, as part of the association, the students for free. So students also attend society meetings, ASC meeting in particular, for free. And they can watch the lecture, sometimes the sit-down meal. If people cancel, we also get them to eat the 3-course meal, not go to McDonald's after. And, we look after those young, because you have to see the young generation, because the young generation becomes the old, and they become the teachers, and they become the specialists and what have you, and the expert dentists and the experienced dentists. So you got to attract them at the start. And so it shouldn't be a financial matter. That's how I would attract those students. And for the new graduates, we obviously, give them a 50% discount, let's say, for the first 2 years as they're a recent grad, just to help them with those initial costs, which can be a big deal at the start of them joining or not joining. And then secondly, in terms of how I choose, or it's not just me, actually, it's the committee that we sort of run it by the committee. I always like multidisciplinary, and I always like the older, most experienced and well-known with the younger, and I always like an international or two or a national. So I don't like to invite the same specialist every 3 to 5 years, and I've been on the committee since 2000, and I might have been 2008 or 9. So I've been on the AC committee for over 10, 11 years. Of and going through the different roles. I love to invite the international presenter. Of course, we've got COVID now, but after COVID, we have plans to invite multiple international presenters next year. I like to mix it, because I can see that the generation, whatever it is, Z, because I must be Generation X or whatever. You guys like these, or more likely to listen to these podcasts, as you said yourself, on your way to work, and you prefer to stay at home and watch some webinars, right? So why don't we mix the ASC New South Wales program, so it's not all webinars, at least one webinar where it's broadcasted to everybody, combined with an international or national speaker that's well known in the industry, combined with some local experienced and non-experienced presenters, combined with other specialists, because it's multidisciplinary. So there's so many facets of in the endodontics and other specialists which interrelate to each other. So for example, the legal side, we may have lawyers or people with medical health law degrees. They may give a combined presentation or a solo presentation on a topic that is relevant still to endodontics and dentistry. So that's how I would attract. I'll give them a great variety and keep on changing, keep on thinking. We will have table topics. I was meant to do that this year, but next year, hopefully, after I'm done as the president, we have a plan. So the vice president, being Dr. Garima Sharma, she's already been chosen as the vice president, who works closely with me. We're in the same practice. So they will have a table topics. So this is like local specialists, young and old, sit at the table with a select number of dentists discussing various cases and topics. All of that, get the participants involved sometimes. Like webinars might be good when you have Q&As and polls and certain ways of assessing what people think. Yeah. And sometimes people are less shy to ask questions when they type it than actually turn up, to a live meeting. So we mix it up.
You also run a mini residency in endodontics. How did that come about, and how do you support your participants during or after it, especially when some of the things that you're teaching are quite high level endodontics?
Yes. So look, it was a program that we thought of after, I call it the entree. The entree was initial programs where they were probably a little bit manufacturer driven, such as I'm a KOL, I admit, for Kerr Endodontics. So we ran Kerr, predominantly product-based courses as well. So I've been there, done that. I've done those courses. I do less of them now. And advanced contemporary endodontics was one where we had all the sponsors and all the products, and we just kept keeping it up to date. It was a 2-day program. We found that people were asking for more. So upon the assessment, the feedback forms, I realized that people want more time. And if we don't offer it, they'll go to London, they'll do the King's College program, they'll go to Italy, they'll do an advanced training in Italy, which is an extended program. I was involved in the King's College program, so I mentored quite a few dentists through it. And I realized, well, a lot of it is theory and them doing their own self-directed learning, if you like writing their own essays and case presentations. Every 3 months they had to have a logbook of cases. Yeah. So I realized we can do a bit of that. They don't have to travel, to King's College, because the travel in terms of time became lesser and lesser since I was involved with that program. So I thought, well, we can probably replicate it and reduce it so it's not taking too much time and money away from the participants. So it was about money, time. They didn't have to travel all the way to, say, London, spend time away from home. Sometimes it's fun, but sometimes, it's affordability and time away from clinical practice. Yeah. And other times, why would they be there so often, where sometimes a lot of the theoretical side you could actually do through other ways. So we reduced the theory part. We didn't get rid of it. It is replicated from King's College, to be honest. Right. With the input of people such as Jeff Young, very smart clinician and a colleague, and I sort of studied with him through Melbourne. Luckily, he was a year ahead. Otherwise, I would have never graduated. He was like he's a genius, really. So Jeff was very heavily involved in devising the program. I moderated and ran it, and so the buck stops at me at the end. But I also am still, even today, even though the mini residencies had a bit of a hold, it's been probably the most jinxed program at the moment, because we have to wait until the New Zealanders can come to Australia to Sydney before we can continue running the program. It's very hands-on. So in that matter, I've been in touch with them. They email me, they Facebook me cases, they ask about various things we taught them and whether they should encounter, when they might encounter unusual cases. So I'm always in touch with them. I'm always, as a general, very open. I like communicating. I really love even speaking on the phone with new graduates, older graduates, catching up with people once in a while. That's part of me as a specialist. I'm very active, if you like. So I would always be supportive of them throughout when they finished. It's not like you finished, I will never reply to you again. Yeah. Occasionally, they've got to remind me. If they send me a whatever message or email, they might remind me because I might forget. I'm only human, but I try my best to respond to as many as I can. And I think that's the way we support them, through cases they tackle, through difficulties they may have after going through such an intense program. Because simply, even in mini residency, being in 4 modules, really 8 days, is still just a little bit off, sort of a small portion of a real true specialist training program where you've seen over 300 patients. So the reality is you've got to do a lot of the self-directed learning, but we give you more. It's a more complete program, if you like, from basic to advanced to super advanced training, and then you sort of see where your level is at. It doesn't necessarily mean that if you do a mini residency, you'll be, you most likely will buy a microscope, but you'll be doing everything that a specialist does. You actually get better at selecting your cases and realizing what you can do and can't do after going through such programs.
I was just going to ask you, yeah, a lot of the times there isn't enough time to, teach and practice all the different exercises that there are in there. But you've just said it. It's just to kind of give you a glimpse and then to help you understand where your limitations are and, what
Yes.
you can feel comfortable doing.
Yes, and other ways after you've done the mini residency or before. You can always, for example, another way, I'm always open to people watching. So not only they can come and watch on a big screen what I do, but they can also on their day off book their patient in. So they can book their patient in, for example, on a Wednesday when they're off, instead of playing golf. They can come with the patient and watch how we manage it. And they can say, we had difficulty with this or that or the other. And as I'm managing it, hopefully I'm able to manage it, they can learn the steps that way. Other courses that are not available in Australia, which I highly recommend, I hope that people are still listening. I'd say in endodontics, it's very difficult to get good hands-on programs. But in the States, I know, for example, Mahmoud Torabinijad in his private center in Los Angeles, he runs hands-on courses for all dentists, but the ones that are, of course, preferring really advanced training. And they have advanced training with patients, so you can actually treat patients.
Wow.
And they got ways to approve that, so you're able to treat patients. And it's very hard to do that in endodontics. And I don't think anytime soon you'll be able to watch live demonstrations. You'll be able to watch your patient be treated by the specialist, but it's very hard to get you to treat the patient. It might not be the same overseas in many other aspects of dentistry as well. It's better you take your patient with you or go to programs where they allow you to treat patients within, of course, strict criteria. Go to the good programs. I'm not saying, to be honest, go to Cambodia and just place implants on poor Cambodians. I think that's a bit unfair. Have your ethics, have your morals, and at the end of the day, select cases, select courses where they're hands-on and they are potentially, you're able to also see patients. And I think those cases are more, people more overseas are more experienced, such as the States and Europe. You can do better courses there, have better mentoring through them, mentorship through them as well.
Yeah, a bit more well developed, and it's been there for a little bit more longer.
Yeah, we're getting there in Australia, but I think never forget when you go overseas to programs, you're not only learning. I mean, I've been to Spain, International College of Dentists. Why did I go to Spain to present? Because I saw like-minded individuals from different areas of the world, or going to the States, and you meet a Canadian, you meet a New Zealander, all that. And you just see they are the same level as you, but they may do things differently, and you learn from each other. So keep your mind open. Never forget that international influence of experienced, operators such as, example is Professor Sorbinijad or Professor Goodacre with over 50 years clinical experience, holding your hand, and they've done these courses 30, 40, 50 years, not times, thousands of times.
Yeah.
Cadaver programs. And we had Prof. Torabinijad come in 2019, if you recall. And
yes.
I organized the cadaver program for him to do in Australia, and it went really well. So hopefully more international presenters will come. And part of ADA and the strategic plan for the next 5 years is to make sure at least one international renowned hands-on course is done from each specialty or facet of dentistry in Australia. So they actually travel here, they do it here, you save yourself the money and hassle of going overseas.
Yeah, that's going to be amazing. I mean, the CPD is continuously changing and improving. Correct. Well, Dr. Mehdi Rahimi, thank you for coming on the show. There's so many more questions I want to ask, but we'll have to save it for another time maybe. If you could let the people know how they can find you or what's kind of going on in your life.
Thank you very much, guys. Thank you for listening. You can find me on Facebook or Instagram, Mehdi Rahimi, Mehdi. I'm also, of course, a specialist, or I run the specialty clinics in 3 areas of Sydney, Chatswood, Parramatta and Double Bay, amongst other specialists, of course, that work with me. And in this group practice, we call ourselves gentleendodontics.com.au. So we cater for the anxious patients. We cater for patients with severe gag reflexes. We do a lot of IV sedation at each practice. So I'm happy to for you guys to, approach me. I'm approachable, whether you refer or not is a different story. I'm not expecting referrals, but if you ever want to chat about anything, private message me on Facebook or Instagram, or email me, mehdi@gentleendodontics.com.au. Thank you so much, Laurence.
Thank you. So for all of our viewers, if you like this episode, drop a comment below on your favorite part, but don't forget to like and subscribe, and we'll see you in the next episode of CPD Junkie Podcast.